We are live, please.
Yeah. Dr. Amita, we are live.
Good evening, everyone. So, it's an honor for us to have you all here today in this class. As you all know, this is a postgraduate forum from us to you. And in this, we are having the third presentation today in the first module. And these are case presentations from our postgraduate students from various parts of Haryana. And I'm honored to be welcoming all of you for this meeting. And we are thrilled to see such enthusiastic engagement as we will today dive deeper into these topics in ophthalmology, right from the anterior to the posterior segment. So we'll be having one talk on blepharitis and then another case presentation on retinal vasculitis. Your presence and contributions will make these interactions truly invaluable for our postgraduate students as well as the clinicians who would like to see these presentations later on. And let's make this evening productive and inspiring. With this, I'll get going and introduce our chairpersons. It's an honor for me to be welcoming Major General Dr. Sagrika Patyal ma'am. Ma'am is a senior consultant and course director DNB and head of department glaucoma at Center for Sight Eye Hospitals. Ma'am has served as the Assistant Chief of Integrated Defense Staff Medical at Army HQ Delhi and the HOD Ophthalmology at Army Hospital R&R Delhi and also as the HOD Ophthalmology at Army Base Hospital Delhi Can. She has also been the professor at Armed Forces Medical College at Pune and is the only lady officer to have commanded the world's highest general hospital at Leh. Dr. Patyal is recognized as a supervisor and guide to PG students by Delhi University and UG and PG teacher and examiner by the MUHS and the Guru Gobind Singh University. Welcome to this class, ma'am. It's also an honor for me to be welcoming Dr. Hitendra Ahuja, sir. Sir is the medical director of Ahuja Eye and Dental Institute and Niramaya Eye Bank. Sir is currently based in Gurgaon. Sir has an extensive experience as a cataract surgeon and as a cornea surgeon and in full thickness and lamellar corneal transplantation and trauma management and keratoconus surgeries. He is also a doyen of anterior segment surgeries and ocular surface surgeries and refractive surgeries. Sir has presented his work in many state and national conferences. Welcome, sir. Um, again an honor for me to be welcoming Dr. Avanindra Gupta, sir. Sir is the director, Nayan Jyoti Eye and Laser Center in Faridabad and is the senior VR surgeon at Center for Sight Eye Hospital in Faridabad. Sir is the HOD of Vitreoretina, has been the HOD of Vitreoretina at Arvind Eye Hospital, Tirunelveli, and he has 52 research papers in his name in national and international forums. He has done instruction courses in AIOS, APAO, VRSI as chief instructor, as well as co-instructor in conferences like American Academy of Ophthalmology, ESCRS, APVRSI, and APAO. Welcome, sir. It's an honor for me to be welcoming Dr. Sushma Tejwani, ma'am, since I also have at one point of time been a part of Narayan Netralaya. And ma'am is the consultant and head of glaucoma services at Narayana Netralaya, Narayana Health City, Bangalore. She has worked as faculty at LVPI, where she was actively involved in the education and training programs and has headed the LVP Zeiss Academy. The other co-chair for the day is Dr. Manpreet Kaur, ma'am. Ma'am is the professor and head at SHKM GMC and Hospital, Mewat in Haryana. Ma'am has contributed to publications on topics like community perceptions of eye health and ophthalmic research from the institution, and she guides clinical case discussions, surgical training in cataract and corneal procedures, and community outreach programs, which are aligned with National Program of Control of Blindness in the Government Medical College. Welcome, ma'am. For the panel, we have Dr. Rajesh Joshi. Sir is the professor and head, Department of Ophthalmology, GMC, Yavatmal, Maharashtra. Dr. Rakesh Shah. Sir is the medical director, Swarashri Netralaya in Mumbai. And Dr. Digvijay Singh, who is the medical director at Nobel Eye Care in Gurgaon. Apart from this, we also have our very own HOS team in the form of the convener, Dr. Inder Mohan Rustagi, sir, and Dr. Rajan Gupta, sir. I would now like to introduce Dr. Preeksha Laklan, who's the VR fellow at the Center for Sight Eye Hospital in Gurgaon in New Delhi, and she will be presenting the retinal vasculitis case, and Dr. Mishti Jain, who's the postgraduate student at Ahuja Eye and Dental Institute, Gurgaon, who will be presenting the blepharitis case. I'm now going to stop sharing my screen. Without much ado, I'll hand over the mic now to our presenters. Dr. Mishti? You can share your screen.
Hello, yes, ma'am.
Now is my screen presenting?
Yes, yes, visible.
Very good evening, one and all present here, respected chairpersons, residents, and guests. I would like to thank Haryana Ophthalmological Society, Dr. Indramohan Rastogi sir, and Dr. Amita Kaul ma'am for giving me this opportunity to present on one of the important eye conditions, which is common worldwide, yet often overlooked in the OPD. So it affects individuals of all ages and ethnicities. So starting blepharitis is a chronic inflammatory disorder of the eyelid margins, as the name suggests, itis, inflammation, blepharitis, inflammation of the lids. It encompasses a group of disorders characterized by pain, itching, redness at the eyelid edges. On the basis of anatomically, it can be classified into anterior blepharitis and posterior blepharitis. Anterior blepharitis involves the eyelid skin, the base of the eyelashes, and the eyelash follicles, whereas posterior affects primarily the meibomian glands and their orifices, the primary cause being meibomian gland disease. So anterior is further divided into staphylococcal blepharitis and seborrheic blepharitis on the basis of etiology. So this is how the staphylococcal blepharitis looks like. In the second picture, we can see the scales and erythema on the eyelid margin. Patient may exhibit eyelash loss and misdirection. Whereas in seborrheic blepharitis, there is less erythema, as is seen in the first picture, and telangiectasia of the lid margins, but there is increased amount of oily scale and greasy crusting on the lashes. In the third picture is a case of meibomian gland disease, in which there is meibomian gland obstruction due to abnormal thickening of the glandular secretions, because of which the lipid layer of the tear film becomes insufficient and leads to dry eye, which is evaporative type of dry eye. So there are three cases. First is a case of a 20-year-old female who came to our OPD with the complaint of recurrent swelling and redness, as you can see in the picture at the medial edge of the upper lid margin, along with itching in the eyelids. The symptoms were worse in the morning. On examination, she had hard crusts at the base of the eyelashes and external hordeolum at the upper lid. So we made a diagnosis of staphylococcal blepharitis. She was managed with lid hygiene, warm compresses, topical antibiotics like moxifloxacin eye ointment, and oral doxycycline 100 mg PD was given for 2 weeks, along with lubricating eye drops. Second is a case of a 45-year-old adult with a complaint of chronic itching and redness of the eyelids for 6 months. He has a history of scalp seborrhea. On examination, greasy yellowish anterior lid margins can be seen, soft scales, and mild erythema of the eyelid margin. On diagnosis of seborrheic blepharitis was made and managed with lid hygiene, warm compresses, lid cleansers, and a short course of mild topical steroid antibiotic combination, hydrocot and chloramphenicol eye ointment given at night for application and lubricating eye drops. Third is a case of a 45-year-old male with complaints of chronic itching and redness of the eyelids for 2 months. There was poor response to antibiotics and lubricants. On clinical examination, cylindrical dandruff in the form of sleeves at the bases of the eyelash was seen, and there was lid margin erythema. So we made a diagnosis of Demodex blepharitis because cylindrical dandruffs are pathognomic of Demodex, and the patient had severe itching and it was a treatment-resistant blepharitis. So we suspected Demodex, and we managed with warm compresses, tea tree oil lid wipes twice in a day, azithromycin eye ointment at night, and lubricating eye drops. So if blepharitis does not respond to routine treatment, we should always think of Demodex. So these were the cases, and now coming to the discussion on the types of blepharitis. Anterior blepharitis, in that we have staphylococcal and seborrheic blepharitis. So they are located on the anterior lid margin, and meibomian gland is on the posterior eyelid margin. Eyelash loss and whitening can be seen in varying degrees in staphylococcal, but it is not there in meibomian gland and rarely in seborrheic. Eyelid crusting is a very characteristic of staphylococcal. There are hard fibrinous scales, matted crusts, and they often accompany ulcerative form, whereas in seborrheic, it is oily or greasy eyelid crusting. Then eyelid ulceration can be seen occasionally in severe staphylococcal blepharitis and not in MGD and seborrheic. So first, staphylococcal blepharitis, it is more common in younger individuals. The symptoms are worse in morning and improve as the day progresses because studies have shown that blepharitis, these bacteria exacerbate the inflammatory process producing toxins. So persistent inflammation of the eyelids causes these symptoms and they worsen during sleep when blinking is absent. The tear film stagnates overnight, leading to lipid buildup and production of inflammatory mediators, exacerbating the discomfort. So the patient will come with complaints of burning, itching, foreign body sensation, and crusting. On examination, hard scales and crustings are found mainly at the bases of the eyelashes associated with collarettes. So these collarettes, as highlighted in the picture, are fibrinous scales and matted flattened crusts surrounding the individual cilia. So the management of this is topical antibiotics and antibiotic creams such as bacitracin, erythromycin. Short courses of topical steroids are helpful in patients with ocular inflammation. So even recent trials have shown that antibiotic and corticosteroid combination can improve symptoms. So they are often prescribed as combination in patients who have not responded to eyelid hygiene alone. Then seborrheic blepharitis. Seborrheic blepharitis, inflammation occurs primarily at the anterior eyelid margin. It is non-infectious, so it is inflammation. There is hyperemic greasy anterior lid margin. That is because of the sebum with soft scales and adherence of the lashes to each other can be seen. On examination, eyelid scaling or scurf, typically oily or greasy consistency is seen. Increased meibomian gland secretions which appear turbid. Inferior punctate erosion, keratitis, or conjunctivitis can be seen in 15% of the affected patients with this seborrheic blepharitis. And in 33% of the patients of seborrheic blepharitis, evaporative type of dry eye has been found. Then next is demodicosis. The Demodex infestation may lead to these cylindrical dandruff-like scaling along the base of the eyelashes, which is very characteristic of Demodex. So these are also known as collarettes, but here the definition is collarettes are a combination of partially digested epithelial cells, keratin, waste, and mitex. There are two types of Demodex, Demodex follicularum longus, which is implicated in causation of anterior blepharitis, and follicularum brevis, which is in posterior blepharitis. So the management is done with lid hygiene and tree tea oil based lubricants. This tree tea oil contains 4-terpineol, which is the effective component. Then pediculosis palpebrum. This is caused by crab lice or Thyrus pubis. These are the adult lice which are found at the base of the eyelashes. The nits are adherent to the eyelash shafts, which are the eggs of the lice, and blood-tinged debris may be noted on the eyelashes and eyelids. This is typically a sexually transmitted and may be associated with pubic lice or other STDs. In children, these findings may be indicative of a sexual abuse. So this is a case which came to our hospital and we mechanically removed the lice, and this is how the lice looked after removal. The case was managed. Then another type of blepharitis is posterior blepharitis, which is the meibomian gland disease. So MGD refers to abnormalities in the function of the meibomian glands. The International Workshop on MGD described it as chronic diffuse abnormality of the meibomian glands, characterized by terminal duct obstruction along with qualitative quantitative changes in the glandular secretions. So excessive abnormal meibomian gland secretion occurs, which can manifest as this thing of the meibomian gland orifices. Pouting, recession, or plugging of the orifices can be seen. So there are various grades of meibomian gland disease on the basis of which they can be graded and treated. Grade 0 is if there is a pale eyelid margin and the opening is visible. I think, ma'am, is the screen still sharing? You can't see.
Yeah, it's
Yes, yes, we can
Very
see.
much.
You are at the grading of MGD. Please continue.
Yes, ma'am. So a pale eyelid margin, meibomian gland opening. Then grade 1 is a pink margin, cloudy expression at some gland orifices. Grade 2, a red margin, milky expression at the gland orifices and increased tearing. Grade 3, a red eyelid margin, yellow continuous expression and we will see frothing at the lower eyelid margin. And grade 4, red eyelid margin, thick yellow continuous expression at all the gland orifices, and also bulbar conjunctival redness. Then next slide.
Mishti?
Ma'am, is the slide changing?
Not moving. Not moving.
नेट स्लो होगा तुम्हारा.
So Wi-Fi is connected, but
Mishti, you can
शेयर करके फिर शेयर कर लो.
okay.
एक बार just click on that and then share. Click on that. Take the mouse on the slide. Click and then press forward.
I think stop share and I will share again.
Share it again.
Yeah, so it's shared. So this was the grading. So this is the summary slide, which is an illustration showing the clinical signs of blepharitis. In staph, we will see hard scales or colorets encircling the eyelash base. And in severe long-standing cases, there may be even scaling and crusting. Eyelid ulceration and corneal scarring may occur. In seborrheic dermatitis, there is sebum, and in demodex, there is this cylindrical dandruff sleeves, which are characteristic of demodex. So I would like to thank my mentors, Dr. Hitendra Ahuja sir and Dr. Shraddha Yadav ma'am, and thank you everyone for listening to me.
Thank you very much, Dr. Mishti. That
Thank
was
you.
an enlightening class. I think we'll go on to the next class. We'll let Dr. Priksha present and then we can have a combined discussion. Is that okay, Inder
Yes.
sir?
Yes, yes.
Okay. So I'll hand over the podium to Dr. Priksha next. She'll be presenting on a case of very interesting case of retinal vasculitis.
मैंने बंद कर दिया.
Ma'am, is my screen visible?
Yes, it is, Dr. Priksha, but we can see all your slides. So maybe put it into either presentation mode or slideshow.
Now, ma'am?
Doctor, can you do me a favor? Can you just stop share for a minute? Dr. Priksha?
Actually, it's...
Yeah, stop sharing for a second, Dr. Priksha. Just stop sharing and then you can reshare.
I've stopped it. Can you just click the share button once? Don't go sharing. Just click the share button once and select entire screen. Don't select the PPT, select entire screen. And also please switch on your camera.
Actually, sir, I'm... Just a second.
When you click share, just select entire screen, top left hand side corner, ma'am.
It's coming only content only.
When you just click on share, you will have a pop-up. On left hand side, you will have entire screen as an option. Yes, can you just go into slideshow mode, please?
Now? Still all slides are visible?
No, doctor. Is it visible to you?
No, only single slide is visible to me.
But
So,
I can see all. I can see all her.
We can
slides.
see all. That's it. That's what I'm requesting. Can you just stop share and reshare this time around? When you click on share button, there is a option called entire screen left hand side. Just let's select that.
In Zoom, there is that green share button, no, Dr. Priksha?
Yes, ma'am.
When you click on it once, it will show you the options.
Can you just stop share first, doctor? Just stop share first. Do you want me to stop?
Yeah, please stop from your side. Actually, it's not showing any button.
Now only click share button once.
Just click it once.
Slowly.
It's clicked. I clicked on it single time.
Left hand side, you have entire screen as an option.
Yeah.
Just click on screen, the entire screen.
Okay.
Just select that and select the share button on the bottom.
Okay. It's done.
Now you can share.
Is it okay now?
Perfect.
Yes, yes, perfect.
Okay. Okay.
Great. Thank
So-
you, Sunilji.
For the disturbance. So, first of all, good evening, respected seniors and colleagues. First and foremost, I would like to express my sincere gratitude to the Haryana Ophthalmological Society.
Doctor, can you also start your camera, please?
Okay, sure. Actually, I just came from the hospital.
All good.
That's
All
okay.
good. We are
Yes.
good. Please.
Everybody is coming back from the hospital only. That's okay.
Okay, and Dr. Amita Cole, ma'am, for giving me the privilege to present on this esteemed platform. So, I would like to begin my case. Again, it's hanging, ma'am.
You need to just stay there and just click on the screen. Just go to slideshow again. Just click on the screen and you should be able to roll the slides. All good.
Is it okay?
Yes, yes, absolutely.
So, a 52-year-old male presented to us with the chief complaint of basically floaters in the right eye since 5 days. History of present illness, it was sudden in onset, not associated with any watering, discharge, photophobia, no history of any preceding trauma to the eye, fever, cough, or any related history. Past family, personal history, nothing was significant. General examination and the systemic examination was completely within normal limit. So when it comes to the ocular examination, right eye was absolutely showed 6/6 vision. IOP was within normal limit. Everything was with normal except anterior vitreous phase showed occasional cell. Whereas the left eye was PL denied. IOP was 6 mm of mercury, occlusive pupillae, and the total cataract was there. So we can clearly see this is a fundus photo of the right eye. With the clear media, mild hyperemic disc with well-defined margins, macula is completely within normal limit, but nasal to disc, we can notice the perivascular nodular infiltrates, perivascular sheathing with the scattered flame-shaped hemorrhagic patches. It like look of an occlusive vasculitis is there. So we performed the fundus fluorescein angiography. As you can clearly see that there is a normal arm to retina time. Then in the early phase, there is a mild hypofluorescence nasal to the disc. And as we go on, this hypofluorescence increases. In the late phase, there is also a marked perivascular staining as well as sheathing around the disc, which is similar to the clinical picture as we can clearly see. So we did the few investigations. Hemoglobin was normal limit, CBC, ESR, serum ACE levels, VDRL, TPHA, and the viral markers were completely within normal. But Montux came positive, 22 mm, strongly positive, and the HRCT thorax shows mediastinal lymph node patterns suggestive of tuberculosis, as clearly stated by the radiologist. So we made the diagnosis of right eye tubercular retinal vasculitis based on clinical phenotype, strongly positive Mantoux test, HRCT thorax finding suggestive of TB, exclusion of other common causes, as well as supported by the court's consensus. Treatment was given, ATT initiated by the primary treating physician. Oral corticosteroid started after 7 days of ATT. Initial dose was 80 mg prednisolone as per the patient body weight and followed by the tapering. So, unfortunately, we don't have the mid-follow pictures, but it clearly showed that during the period of 6 months, that mild hyperemic disc resolved, macula was already within normal limit, nasal to disc, all the hemorrhagic patches resolved, although the remaining was only few sclerosed vessels. We again performed fundus fluorescein angiography at this time also, and we can clearly notice the difference between the initial fundus fluorescein angiography and this time. We can see that the marked blocked hyperfluorescence that was earlier present due to hemorrhagic patches is now resolved. That is perivascular leakage and the sheathing that was very marked earlier is now resolved. The only thing that is present are the capillary non-perfusion areas nasal to disc. So for this, we based on specifically CNP areas, we advise sectoral argan PRP laser. So now comes to the discussion part mainly. So retinal vasculitis is defined as the inflammation of the retinal vessel wall. It may involve veins that is known as periphlebitis, arteries, periatritis, capillaritis, or a combination of both. Isolated retinal vasculitis accounts for approximately 3% of all the uveitis cases. Estimated incidence is 1 to 2 per 1 lakh population. Pathogenesis is basically type 3 hypersensitivity mediated reactions. Causes can be divided into the infectious as well as non-infectious causes. Among the infectious, most common is tuberculosis, rest are syphilis, cat scratch, Lyme, brucellosis, rarely seen. Among the non-infectious, most common is sarcoidosis, Behçet's, SLE, rheumatoid arthritis, multiple sclerosis, and the seronegative arthritis. Then again, it is divided into two based on the which vessels they affect first. Primarily affecting veins are the sarcoid, TB, Behçet's, multiple sclerosis, pars planitis, HIV, and the birdshot chorioretinopathy. Primarily affecting arthritis are the SLE, PAN, ARN, syphilis, IRWAN, idiopathic retinal vasculitis. These are the normal investigation that we all should advise: CBC, ESR, CRP, blood sugar levels, to rule out the syphilis, VDRL, FTA, antibody test, to rule out TB, Mantux and HRCT thorax, and the IGRA test for the toxo, IgG, and IgM for the past as well as the present infection. And these four are the less common. Rest viral markers and the antinuclear antibody, rheumatoid factors, and the serum ACE for the sarcoidosis. Basically, retinal vasculitis evolved through four stages. First stage is stages of inflammation. Perivascular segmental whitish infiltrates with fuzzy borders, retinal edema, retinal hemorrhages. Then comes the stage of ischemia, stage of neovascularization, and then the last stage of complication, that is tractional retinal detachment, non-resolving vitreous hemorrhage, ERM, and the NVG. Diagnosis, gold standard, diagnosis of Mycobacterium tuberculum for the intraocular fluid, indirect evidence from tuberculin test, IGRA test, definite evidence is PCR. Treatment depends on the etiology. We have to treat the infective etiology first, and then systemic steroids are the mainstay of treatment. That can be in the form of oral, intravitreal, depending on the severity of the disease. If unresponsive to steroids, immunosuppressive agents are also added. These few are the four classes of immunosuppressants. Among antimetabolites, methotrexate is most commonly used, and the cyclosporin A among the inhibitors of T cell signaling, and infliximab and the adalimumab are among the biologics. Cyclophosphamide is not used because of the side effect of hemorrhagic cystitis and the bone marrow suppression. ATT is given in the duration of 4 drugs, 6 to 8 months, depending upon the response, and followed by pyrazinamide and ethambutol stopped after 2 to 3 months. These are few of the newer anti-tubercular therapy drugs, but mainly used newer drugs that we have seen are group 5 involves the basically ethonamide, group 3 levofloxacin, and the linezolid in the group 5. ETT special consideration that we have to notice is that ethambutol may cause toxic optic neuropathy. Clinical response usually seen within 3 to 4 weeks of starting the ETT. Ocular and systemic response may not always correlate. A possible reason can be drug resistance or poor ocular drug penetration. This article clearly states that the ethambutol-induced optic neuropathy is proven to be partially reversible only in the initial stages and completely irreversible in the late stages. Earliest signs of the ethambutol toxicity are color vision defect, field showing bilateral central scotomas, OCT showing RNFL thinning and loss of GCC complex, VEP showing loss of latency of P100, although that is rarely response, usually color vision and the fields are sufficient to detect this toxicity. Fundus examination may be normal, or in the initial stages, we can see the hyperemic disc edema, disc pallor, and optic atrophy in the later stages. The incidence of ethambutol-related toxicity is largely dose-dependent. It can vary from 1 to 2% at the dose of 15 mg per kg per day, 5 to 6% at a dose of 25 mg, and the 18% at a dose of 35 mg per kg. As per the new guidelines, unfortunately, dose is very high. Average dose of ethambutol is 20 mg in the children, adults, whereas 25 mg per kg per day, which is significantly high to cause the toxicity. Now comes the role of ophthalmologist in this. Before starting the ATT, we have to perform 3 basic tests, that is visual acuity, color vision test, and the Humphrey visual field test. Whereas monthly, these 3 also advised, and the 3 monthly are field tests that have to be performed to prevent this toxicity. No eye should be lost because of ethambutol toxicity, basically. GRX segment reaction can be seen paradoxically worsening after starting ETT. Cause can be release of mycobacterium antigen, enhanced host immune, which can easily be tackled by increasing corticosteroid dose or adding immunosuppressive agents if needed. So the take-home message is basically we have to prevent the ethambutol toxicity in these cases and have to treat the infectious etiology first before starting or any form of steroids in any form. Thank you everyone for your kind patience.
Thank you very much, Dr. Priksha. That was really something. We started with something else in our minds and it reached somewhere else. Okay. So that's a great takeaway actually, to always keep our minds open when we are in the clinics with our patients. With that, we'll throw open the discussion now. Firstly, I would like to ask expert comments from our chairs. Sagrika ma'am. Ma'am, are you there?
See, I to like both the presentations, both the anterior as well as the posterior ones. And the anterior one, one would think that blepharitis, oh, what is it? But it is so common, and that if we miss the findings, so it was a very good revision class for me, honestly. And what she has brought about is what is the treatment is very important. And another thing which I felt that she has brought out very nicely is that when you see those collarettes, then they are almost like a sure short sign that yes, there are mites present over there. So one has to be very careful. And the fact that we all actually have tea tree oil, and we are using tea tree oil to a large extent, and these are in the form of, instead of using the, look, there are two tea tree oil this thing, varieties available to us. One is in the form of wipes. Now, these are very expensive for the patient. On the other hand, if you take the cleanser, the tea tree cleanser, you just put a few drops maybe in, let's say, tissue paper, or let's say, for example, sterile cotton, and then clean the lid margins. And you've got to show how to clean the lid margins also to the patient. I think that goes a long way in helping the patients out. The other thing which she has brought about is short courses of steroids. Honestly, I was thinking about it in my mind that do these kind of steroids cause any kind of glaucoma, right? Now, the thing is that such short courses, unless you're really steroid positive, which I've really never come across, we have not found. Then, as I said, that since I have not done any literature search on this, I would have liked to see it, but I've not done any. So I can't say whether this is responsible. But one has to remember in one's mind that if you don't tell the patient, please do not use this steroid whenever you want to, that goes a long way in preventing these people from using steroids for a long time. So that I think is very important and a very big take-home message from Mishti Jain's presentation. So I definitely would like to say that, because we always tell our patients that whenever you're using short course of steroids, do that. Priksha, it's a very nice presentation. And what one is that it is unilateral presentation. Am I right?
Ma'am, otherwise was already lost. It was PL negative. So we are suspecting that same thing has happened in the other eye also. Maybe CNP areas were not treated and that landed up in the NVG and ultimately total cataract and occlusive papillae. We don't know the status of the left eye. When the patient came, left eye was completely PL negative with the pressure of 6 mm and the total cataract with the total occlusive papillae.
Okay, so one could not really see it. So yes, I think you did mention thiasis bulbi, but I was very keen to know that were any findings available there. The second thing is, of course, which Dr. Gupta is the biggest, I mean, like he'll be able to give us so much more information on that. All the things that you brought about especially about ethambutol toxicity, are very important. We have seen case after case. I remember in Base Hospital for 2014, we had a case of a lady who, I mean, everything had gone, everything had finished. So that take-home message that you gave about how to follow up a patient of ethambutol toxicity, I think is very important. And I think that we should put it in the back, in one of our gray cells in our heads, and take it back with us that why we can't afford to miss this. So that was very nice. And so please, I would love to hear the others and what are their comments. But thank you, girls, for the presentation. Very nice. I think we all enjoyed it and we learned a lot from you all. Thank you.
Thank you so much, ma'am.
Thank you so much, ma'am. Thank you for your comments. And I would now invite Dr. Hitendra sir for his comments on the blepharitis case. Um,
Yeah. First of all, I would like to congratulate HOS for this initiative, that is the Postgraduate Forum. And today we have eminent panelists and excellent speakers, as we have heard from Dr. Mishti and Dr. Preksha. And the moderation we all know is the best by Dr. Amita. That's always okay. And as regarding the blepharitis is concerned, the blepharitis and MGD, as we say, are extremely common and often underdiagnosed situations. And if we talk of our hospital, that's Ahuja Eye and Dental Institute, 10% of the OPD patients, what we see, are of blepharitis and MGD with ocular surface disease. And there is a clear female predominance amongst these cases. And this is likely to be hormonal or dermatological and maybe a lifestyle factor. And as far as the blepharitis is concerned, it's not one disease. It's basically a spectrum of disorders. We have the anterior lid and the posterior lid and the concerned abnormalities for this. And we have a strong overlap with the ocular surface disease and the dry eye. So we should be kind of very Sitlam, we should not directly switch on to the conjunctiva or the cornea. We should first examine the lids. And I'm telling you, a lot of things which are going in the eye can be tackled with tackling this blepharitis. If we know the cause, whether it is seborrheic or whether it is staphylococcus or whether it is the dermatitis, what we are talking about, we can really help the patient to basically be symptom free. And as far as the second case is concerned, I think Dr. Avninder will be the best person to talk about it. Thank you. Thank you for having me. Thank
Thank
you.
you for your expert comments, sir. Sir, I'd now like to invite Avnindra Gupta, sir. Sir, your expert comments about the retinal vasculitis.
Yeah, nice presentation, both Priksha and Mishti. Priksha, दो तीन questions हैं. पहली चीज कि whether you will say it's a direct infestation of tuberculosis into retinal vasculature. How do you classify? Or you said ki, in your kit, it's an hypersensitive reaction to the tubercular protein. So what do you say about this? Please clarify that.
So there are various articles. Few say that it is a type 3 hypersensitive reaction or there is a direct convection by the blood vessels. It firstly reaches the choroid through the blood vessels and then enters the basically.
नहीं choroid में तो आता है तो choroidal tuberculosis आते हैं, that is pathognomic of tuberculosis. So these kind of vasculitis is an hypersensitivity reaction to the tubercular protein.
Yes, sir.
So how do you distinguish between Eales disease and this vasculitis?
Sir, in Eales disease, it's basically an rule out disease. Means everything has to become so negative and it has to be unilateral. Then we can say it's Eales. Means rest test has to be negative. So it's a diagnosis of exclusion basically.
ये भी तो unilaterally है तो ये भी तो Eales disease. Why can't you label this as an Eales disease?
Everything test have to be. Here is a clear cut evidence on the chest CT, thorax, and the Montux, which is showing.
नहीं Eales में भी it's an hypersensitivity reaction to the tubercular protein.
Sir, in its second eye was also basically involved. We are suspecting it that second eye was also lost due to second is not 6/6 and it's not fine. We are suspecting that that eye was also lost due to this because it left untreated.
See, vasculitis, you can say it's an Eales disease also. It's an Eales, maybe you don't know what is the causative factor.
Yes, sir.
And many times they say ki it's an hypersensitivity reaction to the tubercular protein. The only thing which does not matches in your case is the age. Age of presentation is 54 and generally Eales presents in second or third decade. But late presentation, we can see a lot of late presentations. Now my second question, if you have an vasculitis like this, and it can be an incidental finding ki tuberculosis. Now, what is the primary line of treatment in vasculitis, steroids or ATT?
Sir, for starting the steroids, we have to rule out that it is not TB. If we start directly steroids, there will be a reaction. It can worsen even from the starting point of view. So to
But
rule,
it's an hypersensitivity reaction to the tubercular protein. So with steroids, it will respond. But recurrences will decrease once you start an ATT.
okay, sir.
Okay, so that is the difference. This will respond to steroids. Uh, Third thing, a very important point what you have brought is with the recent change in guidelines of ATT, the dose of ethambutol has been increased in ethambutol in an ATT course. So now what we see more of ethambutol toxicity, and Digvijay will, as a neuro-ophthalmologist, will also tell us yes, he's seeing more number of patients with ethambutol toxicity. Other question is what time exactly after starting your ATT, what is the right time you should start screening your patients for ethambutol toxicity? How many months you will get this toxicity?
Sir,
So if you don't mind, just a minute, Preksha. Sir, can we throw open this question to the panel as to how many months? I mean, because so many people are there who see neuro-ophthalmology, like Dr. Digvijay and Dr. Shah is there, who treats retina. So maybe we can ask the panelists also. Dr.
Yes,
Digvijay, what are your comments?
yes. No. So that I think this is a valid point. We are seeing a lot more of the thiambutal toxicity. We have highlighted this even to the government, and in the pharmacovigilance now, it is something that is reportable. We should report. And I think there's an article in the IGO also on consensus guidelines for managing ethambutol toxicity that was done by the neuro-ophthalmologist group. But I think the idea is that there are two things that you have to look at. One, that, is it being done in the right dosage? So because now you get these fixed drug combination, tablets which are coming as AKT4 or something. So even if the patient sometimes is very emaciated, you may still end up giving him a higher dosage per kg than you want to give. And second is always rule out risk factors like kidney problems or other things. Generally, ethambutol toxicity doesn't happen on day one. It does take some time, and in most cases, it is reported after 8 weeks. But that said, idiosyncratic reactions have been reported even in 2 to 4 weeks. So I think it is something that you have to be alert for from day one, and more so in cases like this where where there is another cause for visual loss, where you cannot rely on the visual acuity and other factors directly for ethambutol toxicity. You have to be a lot more careful. If possible, avoid it.
And actually, once the patient comes to your OPD, the patient does not give say in history they are taking ATT. They'll tell you everything, and they will not tell you they are taking ATT, and you will have to come out uh, with the information that yes, these patients are on ATT, and then you can come to a diagnosis that this is an ethambutol toxicity. They think it's an local problem. So we need to educate the physician also about ethambutol toxicity and importance of eye examination in these kind of conditions.
Yes.
Right, sir. So any comments from Dr. Shah? Dr. Rakesh Shah? Sir, are you there?
Good evening, everyone. Yeah, so we see two different types of set of patient in private and then in government hospital. The government hospital, I see a very rampant ethambutol toxicity coming up, and especially not only on the primary but AKT, the primary drug resistant TB also we got very toxicity to other drug also, not only necessary to ethambutol. And most of these drugs, like if you see many of these patients are already been treated, they just come with the optic atrophy, and when we go in the history, then we come to know actually they had already taken some sort of AKT in the past. Regarding the timing, yes, ethambutol, it is a dose dependent toxicity, but then we see a variation, especially what I see in the government hospital where dose is not been calculated, or maybe it is a overdose or it's a higher dose which has been given, and then patient has not been nutritionally well supported. While I'll say different patient in a private where the doctor has been monitoring, it has been sent to the routine examination either before starting AKT, and also once they already started AKT, usually quarterly, or maybe if there are symptoms, they come early to our hospitals. So that's something is we really have to see the patient where he is getting treated and what fixed drug combination, or it is getting a separate individual drug. That something is going to really matter. A third thing, what we see in a AKT, sometime if you see the skin is totally been reddish discoloration because of maybe clofazimine, because that something is not affecting our eyes. But then if you see the skin discoloration, the clofazimide is something which has been very regularly used in Mumbai, and that also causing a lot of toxicity.
Sir, so what do you suggest? Should ethambutol be discontinued immediately upon suspicion? I mean, I would like to ask the panel as general ophthalmologists also, and Dr. Manpreet is also there. Ma'am works as a HOD in a government hospital, which sees a lot of footfall, and I'm sure because tuberculosis is endemic in our country. And I was at one of these presentations wherein there was a rheumatologist speaking about it, and he said that it should be made as a test for whether you are patriotic or not. So you're only an Indian if your Montus is positive. So that way. So ma'am, so do you think we should stop ethambutol, immediately discontinue it upon suspicion?
Yes,
And
it
what
should be. So I would like to highlight one point, add something. So we had a colleague, he's a surgeon, he's a faculty. So he was on ATT for some shoulder problem, frozen shoulder, whatever. He had tuberculosis. So he developed this ethambutol toxicity at 8th month of the treatment. So he had a 9-month course, but he came to us at 8th month. So his vision dropped, so he didn't disclose at that. Then he said, I am taking ATT. So that the point is that it can develop at any point. Usually it is said it can develop during first 3 to 5 months, but we have seen at 8th month he developed this toxicity, and we have to stop that. So it should be stopped at the moment the patient comes to you with the history of something, vision falling down, or colors not discriminated. So the ethambutol should be stopped immediately, and we usually refer the patient to the chest and TB specialist. To he puts he puts on some alternative medications. So it should be stopped immediately without any other consideration.
right, ma'am. So Dr. Rakesh Joshi is also there. Sir also works as a head of department in one of our medical colleges in Maharashtra. So, sir, what are your thoughts on this? Sir,
Sir, unmute yourself, sir.
sir, you're still muted.
These patients, they usually come to us for initial evaluation whether we should start with ethambutol or not. When they are diagnosed with any ocular tuberculosis, for initial investigations like color vision, field, or whatever toxicity is there, we examine for them. And then if we find that these patients are developing ethambutol toxicity, then usually we refer them to the chest specialist whether we should continue with the ethambutol or not. But usually these people, they stop ethambutol and shift the patient to other drugs for the treatment purpose. I think the final decision belongs to the chest physician only.
Right, sir. Right, sir. So I think I see a doyen of retina in the participants. Dr. Lalit Verma, sir, is I think there in the class. So what an honor to have you here.
Yeah, I just joined actually. I was on my way.
Such an
So
honor
actually,
for us, sir.
it's my pleasure. I did hear part of the presentation of Preksha. Actually, this patient I had followed up for a very long time. And the only purpose I think we wanted to highlight was that ethambutol toxicity is reversible if you diagnose in the early stage. And the best way is, color vision, or you can do, yellow perimetry also, not the conventional white and black perimetry. Because we at AIUS did highlight in, to Government of India, the tuberculosis rampant program, which is going on, AKT3, AKT4 being used everywhere, that ethambutol also, it's a preferred drug by the physicians because it's one of the tuberculocidal drugs, and it's actually very effective drug. But if toxic, believe me, I have published on this also, that is ethambutol toxicity reversible. Yes, in the early stage, yes. But ophthalmologists as well as physicians have to join hands in this. And because in our country, the National Tuberculosis Control Program, the AKT4, as Digvijay was saying, is distributed so freely in government hospitals that you see this problem actually is endemic in patients who are taking ATT. And as far as what Avninder was talking about, whether hypersensitivity reaction vis-a-vis infective reaction, until and unless you do ELISA or you document AFB, you cannot say. But the reason we started ATT was based on the HRCT, because today we should all discourage people, doing X-ray chest. You see a lot of people advise X-ray chest, Montu, quantiferon, everything. But the definitive diagnosis for the ophthalmologist come from HRCT and showing the mediastinal lymph nodes. Which, in fact, people can take biopsy from these lymph nodes and help the ophthalmologist. And if you give only steroids, patient may have a transient response, but is bound to have recurrences. And this patient historically was seeing well with the left eye also sometimes years back. He comes from Ludhiana actually. And this patient was seeing well, but unfortunately lost his eye because of some bleeding inside the eye. That is what was, uh, told to us by history, because he came alone with no other accompanying person. But the message is very, very clear that, you see, apart from our ophthalmologist role is to treat. And we normally, I will never extend ethambutol beyond 2 months. And I will write in red, bold, capital letters, you have to stop this. You can continue Rimpazid or Arcinex for, 8, 9 months, but ethambutol has to stop. And if we don't do that, believe me, patients will, lose vision because. And after that, again, I had another patient, which I don't know whether Prisha remembers or not. We diagnosed ethambutol because of just color vision. Could not read even जो 12 number लिखा होता ना, वो भी
Yes.
patient नहीं पढ़ पा रहा था. So that is one thing I think which should be the message from this PG forum which HOS has started. And I congratulate the HOS also because see, PG Forum is one where learning happens at all levels.
Thank you so much, sir. We're so grateful you could join us and give us your valuable
I'm
time.
really sorry I could not join before, but I was on my way and did hear some part of it on my way.
Thank you,
sir. Thank you.
So, being an anterior segment person, I'm always more interested in how, steroid use affects various conditions. And like we were talking about blepharitis, and glaucoma specialists do contribute valuable input in blepharitis case discussions. In fact, it is a continuing joke among cornea surgeons that we can't run a practice unless there is a glaucoma subspecialty right next to us.
Sometimes,
So, with that, I would like to invite.
Amita, we ophthalmologists behave like dermatologists, that everything is steroids. जहाँ भी कुछ समझ में नहीं आ रहा, whether it is blepharitis, whether it is keratitis, whether it is vasculitis, so everybody starts steroids. And this message should be loud and clear by Sagarika and her group, people who deal with glaucoma much more than we deal, that inadvertent use of steroids. That again we had pointed to government of India from AIOS that steroids का label ही लाल रंग का होना चाहिए. You see, it's very important to danger label हो जाएगा ना तब, then people will be slightly more cautious. Because steroids have an addictive action. Initially, patient will respond, but patient will become so much dependent, and then he will have rise of pressure, then he will have pale this, then field loss, and I will get lost.
So on that note, Dr. Sushma, ma'am, so what in-office treatments like LipiFlow or IPL, which we nowadays use, would be safe to use alongside anti-glaucoma therapy without risking
Yes, of course.
in these
Actually,
patients? Would like suppose there is a glaucoma patient, he's already on anti-glaucoma medication.
So one is that glaucoma patient who's having blepharitis, pneumonitis, or another spectrum to that is glaucoma-induced ocular surface disease is something that we keep dealing with. So there are a lot of other options that we can think of instead of steroids for improving that ocular surface. As a glaucoma specialist, certain things that I would say is there are a lot of combinations that you can use to reduce the preservatives. You can use preservative-free medications, but to support therapy also there are a lot of options now. Now you have like trialo-based lubricants, you have cyclosporins, you have even levetiracetam. Those are the things which can work as anti-inflammatory to take care of the surface rather than steroids. particularly in glaucoma patients, we don't prefer to use steroids. If it has reached to a stage where you have to, the surface disease is so bad that you have to stop glaucoma medications, you can go ahead with surgery and all that. Regarding blepharitis in this case, well, first of all, I should congratulate Risha and Mishti for wonderful presentations, and thanks Amita and Dr. Rastogi for having me here. I learned a lot, and enough has been said by subject experts, so I would not delve into that. The only thing I would want to re-emphasize, as Dr. Verma said, that steroid use in these situations, our threshold should be very high to prescribe steroids in lid conditions, conjunctiva conditions, and surface conditions, because patients tend to feel comfort with that. And how much ever you tell them to stop, when the symptoms are more, they tend to put that old bottle that doctor had given with which I got the comfort. And eventually you keep seeing them with fluctuations. Maybe when you see them, the pressure is okay because they have not used steroids for a couple of days, and in between you keep having those spikes and you keep seeing disc damage. Then those are labeled as NTG, but many of those normal tension glaucomas, if you see, are burnt out steroid induced glaucomas. And so much so, even in children, that even as IPGS Society, we are looking at how much is the prevalence of steroid induced glaucoma in India in children. So that is definitely a very big problem. And I would say that, yeah, we have to be very, very cautious while using steroids in any of these conditions.
Right, ma'am. Thank you so much for your comments. And this was really a great class. I'll just hand over.
No, Dr. Sagarika is saying something.
Sagarika, ma'am?
Yeah, madam, please unmute yourself.
Yeah. I just wanted to say something, and that is that to add to what Dr. Lalit Verma said, all of us, when we are giving steroids, we especially where glaucoma is concerned, are very, very careful. But, I have a very big problem that when a person goes with a normal small problem, it is the pharmacies, the chemist shops who hand this to them. And I think that is one area which should be earmarked, that these people should be told, like Sir said, that this bottle should be marked in red. I think they also should be marked in red, that, please hang on, don't give them these drops in this manner. Because even simple conjunctivitis is being treated with steroids. And as Dr. Sushma said, that then after that, it becomes a big hangover. The moment you have a problem, you go ahead and use it. So I think that is another area which we need to focus on, since this topic of steroids has come up and it is very, very dear to each one of us because we suffer so much because of it. That's what I wanted to say. Thank you.
Thank you for your kind comments, ma'am. Dr. Inder Mohan, sir?
Yeah.
So, before I conclude, would you like to?
And one more thing, Dr. Amita, and
Yes, sir.
regarding the presentation, for blepharitis, it's very important to show to the patient about the cleaning technique, because even though we give the medicine, they really don't know, and then they every time comes with the same problem, especially in the OPD practice. So it's better to show them, let them get the wipes or whatever the Sagarika madam said about the tea oil, and show them actually how to clean it, how to do it at home. A lot of these patients, especially female patients, put a lot of cosmetic, eyeliner, kajal over these blepharitis areas, and that becomes still more problematic. So it's very important to guide them about the proper cleaning technique. So that helps to a good resolution for the blepharitis and avoid recurrence. And thanks Dr. Inder and Dr. Amita, and an excellent presentation by both the presenter.
You see, if I may make a small point here.
Yes.
You see, blepharitis, if you don't, I'm very happy that Rakesh brought out this point. If you don't teach the technique, this will never resolve, believe me.
Yes.
Because blepharitis means we are talking about those glands, which are vertically oriented. And conventional drops, if you put, and the conventional ointment also, they will not, or they will take such a long time. And a lot of people prescribe, you see, Neosporin H or what, along with hydrocortisone drops, and they keep putting. And right
Yes.
technique, believe me, of both, not only ointment, but drops, how to instill drops. Nobody teaches how to put drop. And people will put, 1-2 drops, वो cornea पे लग रहा है, कहाँ लग रहा है, cheek पे गिर रहा है, कहाँ गिर रहा है. And these are very relevant for not only from the point of view of effect, but compliance also.
Right, sir. So yes, this is something that I have learned during my fellowship, that at least the blepharitis patient, every patient you give them 10 to 15 minutes. You explain the medication in detail, how it needs to be used, whether it's the wipes, how the lid needs to be cleaned and all. Because otherwise, this is a recurring problem. The patient keeps coming back. They'll never get better because they don't know how to use the medication unless you actually explain to them. And lid margin is the one part of the eye, I believe, where normally when we put drops, they get stuck in the sac, and whatever is excess gets goes off, but lid margin remains unmedicated somehow.
Yeah.
So it has to be explained to the patient in a language that they can understand, so every time that how it needs to be done. Yeah, so hot compresses and massage with ointment, especially azithral ointment, azithromycin ointment, no financial interests. That it is pretty great because it is considered as a disease modifying agent in blepharitis cases. So over a period of time, it does calm down the ocular surface, but needs patience on part of the treating physician also and on the part of the patient also.
So, Mishti, next time whenever you come, next time in there, whenever you start, you should have one small teaching exercise that how to actually
Definitely.
create the lid margin, which I am telling you, this will go a long way, as Rakesh had said and Sagarika was talking. This is very, very important to teach. You see, I'm telling you, a lot of people will learn out of this. How to tell a patient कैसे करना है इसको.
I think that there should have been one slide or one PPT from the center along with that.
Maybe the next time we'll start the class with that, sir. We'll
Yeah,
have a
yeah,
small video.
yeah. Because PG Forum ka, in their purpose ये है कि all of us learn, and whatever is the take home from today, tomorrow whenever you start again, start with this. But this was the take home. Let me start with this.
Yes, sir.
एक छोटा सा वीडियो बना के डालना है.
Yeah, yeah. No egos hurt.
So, Dr. Misty, please prepare a video. We'll put in the us and you group also.
Yeah, yeah. Very nice.
Sure, sir. Sure, I will do.
So, before I conclude, I would ask Dr. Rajan to comment upon this class. 2 lines.
Rajan is muted now.
Sir. Good evening, sir. Welcome, Dr. Lalit, sir, to the RPG forum, sir. And it's basically a project of Dr. Professor Indra Monastagi to have all the medical college of Haryana on board for the PG students. And we need, sir, your blessings, Dr. Lalit Verma, sir, your support, sir, and your positive suggestions to improve upon the things for us, for the students, sir. And we have earlier had 3 webinars, and sir, we'll keep on doing this for the PG students. I want to enroll all of the Haryana for it, sir. So I need the input from the other colleges as well, sir.
You see, I told Inder that, now Rajan is here, Inder is here, so many, learned people. You should put Haryana on the national map now.
Thank you, sir. We need your blessings, sir.
Yeah. So, very nice.
Thank you, Mr. Rajan.
Thank you, Rajesh Joshi. Also, I'm very impressed the way he was. Rajesh,
sir,
very dear friend also.
Joshi's. So, 3 important points of this PG webinar is communicate, as everybody has emphasized upon, observe, as we do in ATT treatment, and then treat. So, all these things, unless and until we learn these techniques, and of course, we have to see the side effect also. So, this is important, and really thankful to, all the stalwarts and the galaxy of the ophthalmology who have been here, especially Dr. Verma sir and Major Patial and Dr. Avinindra. So, really thankful, Dr. Sushma Tejwani also, for taking out time for HOS podium. And of course, Dr. Digvijay, Dr. Joshi, Dr. Shah, Dr. Manpreet, and especially these 2 young presenters who have, taken out time and presented something unique on this platform. I'm really thankful from the HOS side, thankful to the President and General Secretary. Thank you very much.
Bye. Bye.
Bye, sir. Bye, sir. Thank you, sir.
Thank you. A heartfelt thank you to all our seniors, dedicated colleagues, and brilliant presenters for enriching today's class. And your diverse expertise truly made this an invaluable learning experience for all of us. Your contributions sparked debates and equipped us with actionable strategies We're so grateful for your time and wisdom. Special thanks to Dr. Lalit Verma, sir, for the surprise entry in the class and enlightening us with your wisdom and giving us so much of your time, sir. Thank you so much. Thank you, Sagrika ma'am, Hitendra sir, Avnindra sir, for sparing your valuable time and sharing your experienced insights. And many thanks to the co-chairs, Dr. Sushma Tejwani ma'am, Dr. Manpreet Kaur ma'am, and the panelists for lively discussions. Gratitude to the HOS and the scientific committee for this podium to help in dissemination of knowledge for our postgraduate students. Thank you very much. Have a great evening, everyone.
Thanks to Amita for nice moderation.
Thank
Also.
you.
Thank
Thank
you
you,
so much.
Bhaskar.